the cold chain. The data has to be reported. The immunizations have to be reported within 24 hours to MTrack2, which is the system for tracking vaccinations. Number one, so we can know that they've been issued. But probably more importantly, for this one is that when it comes time for the second dose, we can ensure that individuals get the same vaccine that they got in the first dose. And the usual things for vaccine distributors, they have to account for all the vaccines received, including those vaccines that have expired, those that were wasted, et cetera. And this is the website. We'll ensure to send this slideshow out so folks have the link if they want to sign up to be a distributor of the vaccines. And again, so we've talked about these phased-based approaches before. Phase 1 is the phase that we're in now. So that's the November to December timeframe. So November was really the preparation time, early December preparation time, with late December being the 1A distribution to our highest priority groups. Again, we can expect supply chain challenges as far as the number of doses that are available publicly. And so that means that the initial allocation of vaccine is going to be in closed distribution channels. So our healthcare systems, our healthcare workforce, and our nursing homes in particular are going to be of high priority. The phase 2 is that January to July 21 timeframe, where we can expect that the available doses are going to be somewhere in the neighborhood of 650, 660 million doses available around the country. And this is where the supply chain is going to broaden out. This is where we're going to see supply going to physicians' offices and pharmacies and other settings like that for distribution to the public. And again, we're going to be increasing those individuals that are going to be able to access that vaccine. Our expectation is that the higher risk people are, and their level of need to protect the workforce, such as our healthcare workers, first responders, our nursing home staff, they're going to be the highest priority. As you get younger and healthier, the priority is going to decrease for vaccinating those individuals. And then, of course, phase 3 and 4, the July to October and beyond timeframe, is where we try to reach out to those who have not yet been vaccinated by that time period to ensure that we get penetration, particularly in our hard-to-reach communities, in our vulnerable communities. With that, I will pass it over to Stephanie for the next set of slides.
Thank you, Dr. Escott. I also would like to thank you all for the opportunity to be here today. We definitely consider you all partners of us, and we applaud you for your efforts to just keep us all healthy. This slide gives you just a little bit more drill down as we start to look at the critical populations. And so, as you can see, this was provided to us from CDC, and it starts to look at when we start to look at the phases that Dr. Escott spoke of, looking at the essential workers. So, for example, our healthcare personnel, our hospital staff, EMS folks, long-term care folks, but also really starting to look at what would be another tier for us. And then throughout this process, we've always had to consider the people that are at increased risk because of underlying medical conditions, their age, long-term care residents. And so the green section really goes into additional people that are at risk. We've noticed and monitored during this time the racial and ethnic minority groups, and then in addition to documenting the data on our website, looking at strategies and implementing strategies to really support those communities. And so these efforts in Travis County, we've definitely set up our incident management team to work with these groups. And so we want to make sure that in our planning efforts that we are keeping these areas in mind. As Dr. Escott stated earlier, we have established our vaccine distribution coalition, and that is a regional coalition. And so when we think about folks that are living in rural communities and individuals with disabilities, it's going to be important for us to basically work across our MSA. Also, for us, we also work across our Region 7. Next slide. This was a slide that was provided to us from the Texas Department of State Health Services. As you all know, the State Health Services created a vaccine plan that was released about October 16th, and basically kind of looking at what the CDC playbook would look like. And so what they pulled is they pulled information by region. We are in Region 7. There are about 30 counties that are in this region. And so this was able to kind of pull the number of individuals that kind of fall in these categories. It's going to be important for us as we continue to go through our initial phase, which we're working through now in December. But as we shift to move to our second phase, to keep all of these individuals in our planning efforts, so we can definitely prioritize. We'll definitely be using our data and ensure that we use evidence-based approaches so we can reach folks equitably. One of the things that is in the DISHES plan, and the city of Austin definitely does this in our efforts, we like to ensure that we're providing equitable access to the vaccine to vulnerable and frontline workers. So that is going to be very important. Next slide. This gives you another look at what the phase 1A and what phase 1B can look like. What's going to be important for us is definitely looking at paid and unpaid folks, but keeping in mind, all of the critical infrastructure, folks that may be at risk of severe COVID disease, at risk of acquiring or transmitting COVID, but then also people with limited access to vaccine. These are some key things that we must keep in mind as we're planning our efforts and putting our efforts together. We are working on a communication strategy. And I know some of you may say, what can I do to assist? We definitely would love for you to sign up to be a provider. Two, we would love to share information that we receive, and that way you can share that information with the patients that you work with, whether it's in your practice or a part of the healthcare work that you're doing. Next slide. This just shows us, because we know, and we're comparing it to how things were when we initially started testing folks for COVID. Initially, they were very limited. We had very limited access to testing. And so we are keeping that in mind as lessons learned. And so in comparison to the two, knowing that we have fewer ways to test individual and kits, as we're anticipating, as Dr. Escott said, 1.4 million people, as we know, there are more than people in Travis County than that. And so we have to identify, as we're looking at our phases, to definitely think about kind of who would be within that kind of very first kind of tranche of folks. Definitely would be the hospital staff. and the folks that work in that setting. And so it's important for us to continue to establish and operate point of dispensing pods. And so between now and into the month of January, we're going to definitely be working very closely with our partners to ensure that we are doing everything we can do in that point of dispensing pod. Lastly, I would like to say is that it's going to be important for us to have a system in place that one is able to remind individuals this is your first dose. And then when it's time for your second dose, any type of reminders that we may have in place about returning for the second dose. But it's also going to be a great idea for us to establish within our partners that are providing the vaccine to monitor any kind of adverse reactions to the vaccine, and always offer a place for folks to go. We're definitely going to build that into the public health system. We currently have a medical hotline, and so we're definitely going to have staff that are going to be trained that can have those conversations with folks as well. But it's always a good practice as a provider for you to add that to your list of things that you're working on getting in place. Next slide. That completes our presentation. We wanted to just share again with you this provider enrollment information because we cannot emphasize how important it is for us to get as many providers as we can, here in Travis County. And so my hope is that you would go online, register your organization to be a provider. They will definitely provide you the technical assistance that you may need to receive. And so working directly with dishes. And then we will also would love to follow up with you after you've registered. In the event that you say, no, that's not something I may want to do, we definitely want to work with you to get information out to your patients and provide you all of our community engagement and education information that we're going to be providing to the public. So I will, that concludes the presentation. And so we will wait for questions. Thank you.
And let me just jump in real quick and say that there's a lot of information we don't know yet because the data has not been published in peer-reviewed journals. When that happens, and we expect for it to happen very soon, then we should have more answers. But we can expect that we're not going to have all answers at this stage, even after the peer-reviewed publications. Populations like pediatrics, like pregnant and lactating women, like immunocompromised individuals. The data on these folks are unlikely to be found in the initial vaccine trials. We're going to have to be patient for those and understand that, as with any other vaccine or treatment, we're going to have to weigh the evidence that we have in hand and the risks and benefits associated with that individual patient.
Thanks, Mark. Stephanie, that was a great presentation, a lot of really good information there. I'll start out with a really common question I got a lot. People just wondering if they're physicians in primary care in the community, other than signing up online on that link that we just saw, what else do we need to do to get ready to be able to administer vaccines, and how should we expect that process to unfold? People have questions about, well, I don't have an ultra cold freezer. I may not be able to handle the vaccine. I've heard that they'll come in crates with many vials, and once you open it, you're going to have to use them all up within a certain period of time. So once a person signs up, what should they expect to hear as far as the details of doing all that?
After they have signed up with the state of Texas, the Department of State Health Services will provide them training. That training also includes, how they would order the vaccine. It will also talk with them about, how to handle it. As you stated, it's going to come in the packet actually looks like a little small pizza box, and it actually will have a tracker, etc. But it will tell you the number of days that number of hours it can be room temperature, the number of hours it must be frozen if you have a cold chain freezer, or the number of hours that you can prepare to administer it, and it's in the refrigerator. The other thing that we've done during this time is that we've really applauded ourselves of really working hard with our other partners. And so we've started some conversations about, what would that look like in Travis County at this level. And so there's going to be more information to come from that. We're putting together a group of our vaccine providers as well as healthcare providers. And so that group is going to start the conversations about how do we collaboratively work together with the folks that are on the task force, but then also for other partners that are going to administer the vaccine. So more to come with that, definitely.
Great. Yeah, just to say, that was a great overview, an impossible one. And your comments about what we don't know is also very, very important. And a lot of the questions are things that I don't think you know, but there's some that I think you can answer pretty easily. One is, will you share this slide set? Can we distribute the slide set?
Yes, absolutely.
Okay, great. The next one, and John, give me two this time. The next one, it relates to side effects. So I realize we don't have the publications yet, but we do actually have some information that's been released from, I guess it's the FDA predominantly, released some early information about side effects too. So do you all want to tell folks about what we can expect with the injections?
Yeah, Clay, I'll hit some of those. And again, we don't have all the information, but what we have so far is that the side effects for COVID-19 vaccine look very similar to side effects from things like the flu vaccine. So I'll give you a little bit of data. For the Pfizer BioNTech product in the 18 to 55-year-old age group, about 60 to 80% reported pain at the site of injection. 8 to 10% had fever in that group. More commonly, some chills, some myalgias, headache, those sorts of symptoms. In the 65 to 85 group, actually, there were a lot less symptoms. So 33 to 67% with pain at site, 0 to 8% with fever, and less than 50% with the other associated symptoms, the chills, the fatigue, etc. So by and large, mild symptoms that we expect to see with things like the flu shot. The AstraZeneca trial was halted. There were 2 patients, I believe, in the UK and 1 in Brazil. Total of 3 patients that had concerning events happen. The independent monitoring boards determined in all those circumstances that they were unrelated to the vaccine administration, but no severe side effects or concerns with the Moderna or the Pfizer vaccine candidates.
Clay, did you say you had a second question?
Oh no, my first question was about whether the slides would be available.
Yeah. Oh, got it. So a lot of people were wondering, as a physician, when will you know that it's your turn to get the vaccine? Obviously, we would expect the pulmonologists and the nurses in the ICUs and the respiratory therapists and the hospitalists who are taking care of COVID patients to be among the first group to get vaccinated. But then for other physicians who are maybe not quite so on the front line, how will that process play out? People are just kind of wondering, how will I know when it's my turn to get the vaccine?
Well, and again, we do have to focus on where the risk points are. And I wanted to stress this a little bit, so I'm going to say it again. We know that if you live in a nursing home or long-term care facility, your chances of ending up in the hospital, ICU, or dying is substantially higher, even when we match your age group, than those who are not living in those facilities. So that's a really high priority, because if we can avoid the hospitalizations and critical care stays and deaths, we can avoid a lot of the exposures on the hospital side.
Right.
Then I imagine, as you've just described, John, that we're going to have to tier within the I work in a hospital group. And hospitals should prioritize those who are more likely to have substantial exposure. ICU, emergency, people obviously staffing those COVID wards are going to be the ones who need it, and then roll out from there. My guess is that physicians and nurses and staff working outside the hospital or emergency setting are going to be looking at the probably February, March kind of time frame for availability. But our plan would be to share publicly those processes. We're working on a ranking system similar to what we did with our testing early on, to assign points based upon individuals' risks and need for prioritization for COVID-19. It's not a done product. We're still in discussions about that, but we do intend to make it clear to folks when it will be their turn.
Great. Lots of questions about who's paying for this. So we know we've been told it should be free to everyone who wants it, but how is that going to actually work? You guys are paying for it there at APH, or is it insurance will pay for it whenever it can? How's that going to play out?
Well, what we have been told, as you have, is that the vaccine itself is going to be free. So as a provider, we cannot charge for the vaccine itself. But what a provider can do is a provider can charge an administrative fee. And so definitely folks that, have insurance, et cetera, and are able to look at what that administration for me. I'm in a private practice, and I'm, providing services to my clients. And so I need to look at what would it cost for my patient if they were there for a routine visit. It'd be similar, like any other vaccine. But if the person is coming to me and they've not scheduled, then that provider will need to kind of think about what does it cost for me to administer this, and determine a reasonable fee. And so that is how some of the providers are going to be able to recoup their costs, because, the administration of it, you have to pay the people that are providing the vaccine.
Along those lines, one thing we discovered when we were trying to ramp up testing is that simply the availability of swabs was a rate limiting step. And we all started finding out what a flocked swab was. Is supply of syringes and needles, or just enough personnel to actually give the injections, a possible rate limiting step, or is that unlikely?
I actually think the federal government has done a good job of preparing for the supply chain issues by securing contracts for the syringes and the needles and alcohol swabs and so forth. So my hope is that we don't run into those issues. I think we'll have to wait and see. But I'll tell you, there's the fact that we have a vaccine candidate in less than a year is a remarkable feat. We may face some challenges. I would imagine they're going to be short-term challenges with the supply chain issues, but I feel fairly confident that they won't be a long-term issue going into the spring.
Great. So lots of questions about people who have either had COVID or have antibodies, and whether they should be vaccinated. Any word on that now?
Clay, I think the thinking right now is that those who have had a COVID-19 clinical syndrome probably don't need to be prioritized for a COVID-19 vaccine right now. Obviously, there are lots of unanswered questions about how long-term that immunity is from a natural disease. Similarly, we don't have answers for long-term immunization from the vaccines that we're talking about. But I think they're going to be a lower priority for now.
There are questions about this vaccine has to be given twice. I think it's 21 and 28 days apart. So it involves tracking. It involves getting people back in for their second vaccination, and knowing that they did or didn't come back in. And also having that second dose available. So if there's a slowdown in supply and a person can't get it right at 21, 28 days, and it maybe ends up being another couple of weeks before their second dose comes in, does that matter?
I don't know. Again, these are some great questions that we just don't have answers to. We can expect, as with other vaccines, there's going to be probably a grace period between when you should have received it and when you actually did. At some stage, it's going to reset. Again, we'll have to wait on the publications and the recommendations to answer that question.
And what about the part about following up on a patient that has been immunized once and they're due for their second one? How is that tracking going to happen?
Yeah, and again, I think it's going to be a shared responsibility. We're working on a process on the public health side for that, but it is going to be important as individual hospital systems and physicians' offices to ensure that there is a process for ensuring that folks come back for that second one. I can tell you that the quicker that we can get enough people vaccinated, the quicker we can get back to our athletic events and doing things as we were before. So I think should be a great deal of incentive for us to really be vigilant about tracking those folks down and paying close attention to our that second dose.
By the way, we're not going to get to all these questions. I feel like you guys are doing a great job of answering these questions, and I'm running through them and clicking them off when you've gotten to them. But man, so we still have 63, and as fast as I go, they keep increasing. So just to let people know, we'll do the best we can to get to the ones that we can get to. So this one is a good one. So the question, we know that there's a lot of concern in the community about the safety of the vaccine. A lot of these questions relate to safety. And that there are a lot of people who are saying today, particularly some of the most vulnerable populations, that they are not going to get vaccinated, that they're concerned about safety, or concerned about some other aspect. So what are we doing in our community to get the message out that it's important to be vaccinated?
Well, there are some, as a part of this process, we must develop community engagement marketing materials that are specific to the vaccine. That information that we are planning to put together, one, we are going to be working with members from our Vaccine Coalition Committee to provide some additional input to us. But some of the things that we have tried and have worked very well in the past is one, being as transparent as we can be, sharing all the information that we have, being available to answer any questions that individuals may have. The other thing that is really important for us is we had a flu campaign earlier this year. We used leaders to be a part of that little small brief commercial that we put together. And so being able to use ambassadors in our community, we're definitely going to look at a survey to determine the attitudes that folks may have about the vaccine. There was another survey done with Sendera and their patients. And so we're wanting to repeat that as well. And, based upon some of the information we received from that, really try to tailor and target our outreach efforts to address those concerns. But we are definitely hearing that as well. And we're definitely going to be working on that as a community, because our goal is that we really want the most vulnerable folks to be able to receive the vaccine.
And that's also one of the reasons why we've included community advocates in this large coalition, to help us hear those concerns and tailor the messaging for those communities. I think, people are nervous because the politics leading up and the conflicting information about vaccine. I think they're concerned about the fact that this is a new technology, this mRNA and DNA vaccine. But, I think once we can explain that the vaccines work in a similar way to the natural virus, right? The natural virus enters the cell, enters the nucleus, hijacks the DNA to reproduce, then that it becomes less science fiction and more science fact. And I think the more that we can do that as a medical and scientific community, I think the more comfortable folks will get with this concept of this new type of vaccine.
Can you comment on who is qualified and allowed to give the vaccine? Allied health, outside of physicians' offices and nurses and such, pharmacies.
Do you want me to answer, Stephanie?
Oh, go ahead. Go ahead.
Yeah. So if you're qualified to administer vaccine, you're qualified to administer COVID vaccine. Again, there's going to be differences in who gets this first batch, and that's going to be in the closed pod system. But we expect to use our normal folks who give vaccines.
I think maybe the other thing I do need to share is we've worked with students. So whether it's students from the nursing school, from the pharmacy school, from Dale Med, and so we've put some agreements in place and have done that before with our flu vaccine. And so we're definitely wanting to encourage others to be able to work with students and give students that opportunity, as long as you've trained them and you feel confident in their ability to provide the vaccine. But we've used students as well.
Great. Yeah, so this is related to that in a way. I mean, this is obviously we live in a great community and we have a lot of people who are ready to step up. And so some of our folks, retired folks in the community, are asking, can they be vaccinators? Is there a way for them to volunteer, at least help in the process? So I don't know, we do have some of that here at Del Med for sure. We have some opportunities like that. Do you all at APH, or do you have a way to get more people there helping us?
Yes, we are able to have volunteers that work with us. We just have a orientation type process, some documentation they need to sign, confidentiality agreements, etc. But we are able to work with volunteers.
Great. Owen Winsett and several others have asked questions about getting vaccinations for family members or household members of people who are at high risk. Well, those folks they'll have to fall in. Yeah, I would probably just fall in just as it plays out, I imagine.
Yeah, that's right, John. Really with that phase 1A, it's really going to be focused on the people who are doing the work. Obviously, we are concerned about other people in those households, but we're going to have to wait on those. I will say that An important note is that we don't yet know if these vaccines will sterilize the individual. And what I mean by that is prevent them from getting infected. We know it's effective at preventing disease, symptomatic disease, but there is some evidence that it may also be effective enough to prevent actually, replicating the virus and being able to transmit the disease. So we'll have to wait a bit longer to find out that information. If that is true, if it does prevent the individual vaccinated from spreading the disease, even if they are exposed, then we're talking about a timeline of returning to normalcy and having a big bonfire for the masks much sooner.
Great. Well, hopefully it won't sterilize us, although for some of us it might not be such a bad thing. But we know what you mean, Mark. So this is just an idea, and I think it's a good one. It's that, once the trials come out, can we have another one of these sessions to really go through them in detail? I think that's a great idea, because all of us are just relying right now on what we've heard, little snippets from either the FDA or from Pfizer, from Moderna, not the real peer-reviewed trials. So we can do that and bring folks back and bring some other scientists in to look at that once they're published. This other question is more about, and I think this is an idea, so I'm sharing the ideas. A hotline. So this is going to be confusing to people. Where do I go? Do I need to bring my insurance card? All that stuff. Are we prepared for that? Will APH have something like that set up?
Yes. Yes, we will definitely expand our current footprint of our medical hotline. As you all know, most folks call 311 and, there may be some high level questions that they can answer, but they'll immediately patch them over to our hotline. And like I said, we're going to expand our footprint. But we are also asking that if you are going to provide those vaccines, allow some of that within your practice as well.
Can you talk a little bit for the pediatricians who are listening about vaccinating children?
Yeah, John. So, again, obviously, because these are early trials, it doesn't involve a lot of pediatric patients. The Pfizer is expected to be approved for 12 years and older. Younger kids, we don't have data yet. So again, it's, I think we're going to have to be patient to see what the final recommendations are. I imagine it's going to say something like, you may consider in younger if the benefits outweigh the risks, but we don't have a lot of information about this vaccine in pediatrics. Luckily, for the most part, children don't have a severe disease. We have seen some cases here. We have seen some hospitalized. There obviously have been deaths of children around the country. But I think we'll have to be patient on the data as it relates to children.
So some questions about timing. So and you all gave a range there. So let's just sort of talk this through. So there are a bunch of people on this call, no surprise, that are in the 1A group, right? So practitioners that are caring for people with COVID are likely to run into one in their work. So it sounds like FDA is meeting on the 10th, the advisory committee. The FDA has said, because I was on a call with them on Monday night, that they will take no more than 10 days to make that decision. Now, they didn't say it's going to be 4 or 2 or 3 or 7, but they said no more than 10 days. So we know, too, that the shipments are all ready to fly here. So best estimate then puts this somewhere the 17th, something like that, of December.
Yeah, Claire, I think 17th, 18th is probably realistic.
Yeah. And then in that 1A, so on Tuesday, the CDC changed its stance a little bit from that slide that you guys showed. And they said basically that, frontline in the hospital, emergency room, number one, along with nursing home residents. So is that what you're thinking we're going to be doing here too for 1A?
Yes. And,
Yes.
I think my opinion is the nursing home residents should be the 1 AAA, because that's where all our risk is. And we've talked about this from the beginning. If we can effectively cocoon or insulate those very, very high-risk people, our hospitalization, ICU, and death curves look much different.
Yeah, and we're still seeing cases in those places, right? In spite of all the things that we've done to try to reduce the risk there, there's still outbreaks in our nursing homes. So, yeah.
That's right.
Good. Well,
I
John,
would also add that the other area that we're anticipating is our EMS providers will definitely be kind of early on within this initial phase as well.
Some have asked, well, which one should I get? Personally, I'll take whichever one comes my way first. Both are effective and have very safe profiles. Do you have any comments when people ask that question?
Yeah, John, I feel the same way. I mean, obviously, we need to wait for the data to be published so we can chew on it a bit more. There may be some distinctions between the two, but they both work in basically the same way.
Right.
So I'm with you. Whichever one goes in my arm, it's probably going to be fine with me.
Yeah, I agree. Let's get them here. Those first two they look almost the same. I mean, it makes sense. They kind of work the same way. So, but both really highly effective. The AstraZeneca one, I don't know. We're going to have to really look at that data. That doesn't look like it works nearly as well. So, but they may be able to get more vaccine quickly than the others.
Yeah. Well, again, I want to point out that the AstraZeneca endpoint was different. Mm-hmm. So they were actively surveilling people for disease. What we don't know from the Moderna and Pfizer trials, at least so far, is were there a bunch of asymptomatic cases that they never knew about. My intuition is that it's not going to be 90 or 95% effective. It'll be really good, but not quite that good. But we'll have to be patient and wait and see.
Great.
Well, Clay, some of the critical research for the Moderna vaccine happened right here at UT Austin, right?
That's right. Jason McClellan was the guy who figured out how the spike protein folded and where antibodies should be made to fit into it and all that stuff. And yeah, we've had him on here, right? And so the group has had the benefit of meeting him. So it's great to see, huh? Actually, what happens here, you know what they say.
That's what they say.
So, so this has been a great session. Learned a tremendous amount. And no, we didn't get to all the questions. In fact, they're continuing to increase, 80 questions. It's not really feasible for us to answer these questions afterwards. People ask, could you email out the responses to the questions? We can't really do that. But come back. So we will do something. I think that's a great idea. It'll be in January to review the actual data from the trials. Again, come back for Anthony Fauci. Oh, and CME, if you want it, look in the chat. There's a link there. It'll also go out to folks after this call that registered. John?
I'd like to thank everybody for joining us today. This was a great session. I'd like to especially thank Stephanie and Mark for taking time today to give us an update. We learned a lot. Clearly, there's a lot we don't know, and we're just going to have to be patient. And it'll all get figured out, and we'll get vaccinated, and we'll make progress with this thing. But we just have to be patient in the meantime. But I appreciate all my colleagues and all the work that everybody has done. I think we've done a great job here in Austin. Our curve is a little flatter than other areas around the state, and that makes me proud. And I'd like to thank Clay for joining me on these sessions. It's been a lot of fun. And I'll leave you in good hands with Nancy Foster starting in January.
Great. Thank you, everybody. Thanks again.
Thank you.